Welcome to Tele-Derm National. Tele-Derm provides online education and consultational services in dermatology for rural and remote doctors and has now been a part of Romeo for almost 9 years. The idea for it came from my experiences providing a visiting dermatology service to places like Mackay, Longreach and Mount Isa. What to do with patients who present between visits? Similarly, what about the patient who needs review? It was all very well giving doctors advice, but to carry out the advice, these doctors also needed training in dermatology. They need to be able to take a history, recognise clinical signs, take high quality clinical images, perform procedures such as biopsy and excision, and be familiar with the use and side effects of the wide array of available dermatological treatments. What I want to do now is walk you through the site and show you what it has to offer. Broadly speaking, we wanted to provide a site that would allow ready access to education in all aspects of dermatology, as well as specific patient advice. This needed to be available 24 hours a day, 7 days a week, and be user-friendly. We wanted it to be interesting and to meet the needs of users at any stage of their career, so from medical students upwards. Most of the educational content is case-based and in a question and answer format. The idea being that users can see how a specific patient was diagnosed and managed and then perhaps apply that experience to their own patients. For specific patient advice, we've always used store and forward rather than video conferencing. There is now endless literature documenting the exactly similar accuracy of assessment of skin conditions via digital photography and face-to-face consultation. Store and forward is convenient for both the referring doctor and their patient and for the person providing teledermatology advice, in other words, me. We've been able to answer almost all cases submitted over the last 9 years within 24 hours. This is a faster turnaround than can be achieved with face-to-face or video consultation. We may not always be able to give a firm diagnosis, but that is not an uncommon experience in usual clinical practice. We can often say what is not going on and we can guide further investigation and treatment. Here you can see the opening page. All that's on offer within the site is listed here. Cases, quizzes, journal reports, photography courses, surgical procedure tutorials, cases submitted for advice and more. The cases can be used in two ways. You can click on the condition index and look up the condition you're interested in. For instance, mastocytosis, or benign migratory glossitis, or perfume allergy, and specific case studies from my practice will appear. Each shows images of the condition and then a series of questions which showed the user how to approach such a patient from taking the history through examination to investigation, diagnosis, treatment and follow-up. Skin cancer diagnosis and management is dealt with at length in our Dermoscopy Atlas. Here we can look up specific diagnoses such as melanoma, basal cell cancer, Spitz nevus or more. We can also find examples of specific dermoscopic features such as arborizing vessels, negative network, red saccules and so on. Each skin cancer case deals with historical, clinical as well as dermoscopic features, and most importantly, management is dealt with at length. I'm told that people often use these cases as material for tutorials for medical students or trainees within their practice. Then, you may want to test yourself, and so the cases can be accessed in a blinded fashion. Click on a numbered case and you can pit yourself against it. For example, case 544 allows us to see a nice example of a common condition. Each question is accompanied by a detailed answer which then leads you into another question. By the time you have finished, you should be more than familiar with this condition. At the end, you can also do a true-false quiz and so earn CPD points. All your activity on the site is automatically recorded. When I first started supplying online advice, it was very common to be asked how to do simple procedures such as skin biopsy or curettage. If we look in other resources, there are detailed online tutorials in procedural dermatology. These have been written with medical students in mind and thus cover everything from site selection, anaesthesia through to dressings. For the more advanced, there are streaming videos of Dr Dan Kennedy plastic surgeon performing excisional surgery. We also provide advice on acne, Effudex, suture techniques and many other things. Keeping up with recent advances in any field of medicine is difficult. Tele-Derm offers reviews of articles felt to be of interest to clinicians. For example, Journal Report 112 deals with the simple method of closing difficult leg wounds. 104 addresses the patient with delusions of parasitosis or so-called Morgellons syndrome, whilst 108 explores imiquimod and its role in the management of lentigo maligna. Many rural and remote medical practitioners work by themselves and so suffer from professional isolation. An online service goes some way to reducing that. Tele-Derm offers a weekly quiz that allows you to pit your wits against a case along with your colleagues. This one, posted on the 25th of August 2012, is typical. An area of biopsy-proven spongiotic dermatitis unresponsive to usual treatment. Each respondent gets an answer and, if needed, guidance to cracking the case. As can be seen, the cases are usually interesting and attract numerous responses. Finally, we have our specific patient advice. This service has received 570 cases for advice since July of 2010. A typical case was posted on the 29th of September 2012, a small girl with a facial eruption. The referring doctor was in the right ballpark, but one can see that this is very likely a lip-lick dermatitis, and by referring him to two similar cases in our library, cases 2 and 526, he was able to convince himself and, more importantly, the child's mother of the nature of the condition. Some cases are so rare that I've only ever read about the condition, as with this one submitted on the 16th of September 2012. Linear erythema like this can only be a few things. We put forward the possibility of the quite rare shiitake mushroom flagellate dermatitis, and sure enough, she'd been eating these the day before. In both of these, the turnaround from submission of the case to my response was less than 24 hours. In 1987, I did a locum for Bruce Chater up in Theodore, and my experience of 3 weeks of solo rural general practice made me commit to a career in dermatology. Bruce recently sent me this case of a 10-month-old child with syndactyly hyperspadias in depigmented areas. Now, if you look at my answer, which came within 24 hours of Bruce submitting the case, I thought about a number of things. However, one of the big things to exclude with this history is Waardenburg syndrome. I've given Bruce a very detailed answer and told him what features to look at, and Bruce has found that this child did indeed have a number of clinical features consistent with that diagnosis, and so we've arranged review with a paediatrician.
Yeah, I'm a real fan of Tele-Derm because it allows me to get an opinion from a dermatologist, Jim Muir, very quickly and easily. This case is just about a little kid who had a constellation of some abnormalities, syndactyly and hyperspadias, and a strange sort of rash on the knee, so I could get. Mum was kind of, what do I do about this? And I said, well, we'll get an initial opinion anyhow from Jim. We took some photographs. Actually, that's an important part of getting it right. You need a little photo resizer, which I found, and thanks to ACRRRM, and that means I can get good photographs off. And Jim had a look at them and actually gave me sort of a differential diagnosis and a bit of a checklist of things to go through. So I could then get Mum back in. She was pretty delighted that we were taking that interest in her. And the child, we could reassure her that it didn't seem to be anything too nasty, but it needed some further opinion as to just which of the syndromes it might fit into. And so we've sent her off to a paediatrician who visits the next town. But that won't be for a couple of months, and having that reassurance straight away was worth its weight in gold.
This is a nice example of how a rare condition can hopefully be diagnosed early with minimal inconvenience to the patient or his family, and with a service in a rural area equal to that of what he would have achieved if he'd flown all the way to Brisbane or Sydney or Melbourne. Here's an interesting case submitted from Townsville of a very typical presentation of a reasonably unusual condition. If you've seen this before, you'll recognise it readily. If you haven't, it'll give you some difficulty. I was able to guide Chris to cases 152 and 353, which are of exactly similar conditions. This is a pigmented purpuric dermatosis. These cases showed him similar cases. They also showed him how to investigate the condition and how to treat it. This case from August illustrates the way that we can use store and forward to expedite management of a patient. This was quite a complicated condition. It was a little bit uncertain what was going on, and as you can see from the series of posts, we sorted it out over a few days and a number of posts. This would be very difficult to do with video consulting. Here's a case from Port Lincoln in South Australia. It's often said that a dermatological emergency is any rash that's on a doctor. Here, I think even the most hard-bitten of us would say that this is indeed a dermatological emergency. You'll note that the case was posted at 14:25 and my response came at 15:55. This lady is in serious trouble with this rash. We were able to give the doctor a series of possible diagnoses and management advice, and even refer her to a couple of similar cases already posted on the website. Not every case we get is an inflammatory dermatosis. We certainly get asked for advice on how to treat skin cancer. Here's one from the 26th of July, a very nice image showing what I thought was a keratoacanthoma. However, the eventual excisional histology showed a squamous cell carcinoma with keratoacanthoma features. This case was submitted on the 25th of July at 7:30 and I replied at 3 minutes till 10. The patient thought she'd been bitten by a spider. When you look at this image, it almost certainly has to be herpes. We advised the doctor of that and the swabs confirmed the diagnosis. All done within a couple of hours. It's important to remember that all of these cases are available to any user of the site. This means that we can almost get the situation of a general dermatology outpatients clinic happening. You can sit in on cases, see what happens, see what the presenting dilemma is, and see what differential diagnoses and management plans we come up with. This is a way of accruing valuable clinical experience which wouldn't be accessible to most of us otherwise. So, where to in the future? Obviously, we'd like to keep going. We are continuing to grow the number of case studies and journal reports. We've recently finished filming some advanced surgery with Dr. Dan Kennedy, plastic surgeon. We remain hopeful that the government will provide funding for store and forward telemedicine consultation, not just the more time-consuming and less convenient video consultation method. And one day, I hope to put out a quiz of the week that no one can answer.